Good evening. My presentation is on the trinucleotide repeat expansion disorder known as myotonic dystrophy. I hope I will convey the background of the disorder to its prevalence and most importantly the genetics behind it. Myotonic dystrophy is a chronic, slow-progressing multisystemic disease with a high variability in inheritance and symptoms. It is the most common adult-based form of muscular dystrophy. Due to its systemic nature affecting multiple organs, there is an array of clinical symptoms, but is mostly characterized by the wasting of muscles, the formation of cataracts, heart conduction defects, and myotonia, thus leading to high morbidity rates within patients who suffer from myotonic dystrophy. This image is used to underline how systemic the disease is within a patient, especially within type 1 of the disorder. Type 2, on the other hand, possesses similar pathologies, however at a milder level. Myotonic dystrophy was first described in 1909 via its clinical features of muscle weakness and myotonia. This was known to be Steiner's disease, or in the modern day context, DM1. In 1992, the gene of cause was discovered as being the Dystrophy myotonic protein kinase gene, or DMPK. The gene has become altered by possessing an unstable trinucleotide repeat, which lead to conformational changes within the RNA. In 1994, a second type of myotonic dystrophy was differentiated from DM1 as being a milder form and being caused by a tetranucleotide repeat within the CNBP gene, and again leading to an altered version of mRNA being formed. DM1 has four forms which have an array of clinical features, most of which are similar but vary on severity of symptoms. Congenital DM1 shows a distinct clinical phenotype with distinct clinical features. After birth of the patient, they usually suffer from general weakness and respiratory compromise. Infants tend to show improved motor functions over time before their prepubescent years. However, respiratory failure within those years is high. Cognitive and motor milestones are delayed, thus the need for special needs schooling. Childhood onset, on the other hand, usually show heart conduction abnormalities such as arrhythmia. Adult onset, on the other hand, they tend to have a lot of distal muscle weakness, and thus having problems with the fine dexterity of the hands and feet. And the face tends to show this appearance of a hatchet look. Adult onset DM patients also suffer from arrhythmia, which in both cases of adult and childhood onset can significantly increase the morbidity and mortality. Asymptomatic DM1 sufferers show very little symptoms of the spectrum. However, cataracts can form, and usually does, and it's helpful in identifying the transmitting person. Type 2 of the disorder typically appears in adult life and has variable manifestations, such as early onset cataracts, which is usually forms at younger than 50 years old, varying grip myotonia, thigh muscle stiffness and muscle pain, as well as weakness. Symptoms of DM2 usually begin in the 2nd to 6th decade, and patients as well as their care providers ascribe them to overuse of muscles. This slide shows the similarities of the two types, but possesses enough unique features to be distinct diseases, such as DM1 patients are mostly affected by distal muscle weakness, whilst DM2 patients mostly being affected by proximal muscle weakness. Another major difference between the two types is the lack of a congenital form for DM2. As mentioned before, in the most common form of adult muscular dystrophy disorder throughout a population, interestingly, DM seems to have great prevalence in European and North American populations, with incidence being 1 in 8,000, whilst incidence in Asian countries such as Japan is 1 in 20,000, and significantly less in the African population. This is an indication of founder effect within the different population types. Type 1 seems to be the most common form of myotonic dystrophy. However, recent studies suggest that type 2 be as common as type 1 in certain Caucasian populations such as Germany, Finland and Poland. The prevalence of DM2 is not well established, and the research is contradictory for both types, especially with the numbers not representing patients who have never needed to be diagnosed due to them being asymptomatic, or elderly patients over the age of 70 who are thought to be naturally undergoing muscle degeneration. In terms of inheritance, myotonic dystrophy is an autosomal dominant disorder, so there is a 50% chance of inheriting the mutant gene from a parent, and thus the disorder, be it type 1 or type 2. The phenomenon known as genetic anticipation is shown to take place within myotonic dystrophy type 1, and so future progeny who inherit the mutant allele will also inherit one with expanded repeat regions, and thus the pathology of the disease can be seen earlier in life and more severe compared to their parents. In the type 2 of myotonic dystrophy, the mutation is short in next generations, thus showing a lack of anticipation, and may explain why there isn't a congenital form. Why is the size of the inherited repeat DM2 patients smaller when transmitted is unknown. A gene defect in the DMPK or CMBP gene leads to the formation of myotonic dystrophy type 1 or type 2. The defect disrupts the formation of a functional mRNA which codes for the DMPK gene. Modified genes can exaggerate the effects of myotonic dystrophy type 2 and thus can be responsible for the large variability of DM2. The function of the DMPK gene is to synthesize the DMPK proteins. The function of this protein has not been determined fully, but it appears to affect the function of muscular, cardiovascular, and neural tissue. One known function of the DMPK gene is its ability to inhibit myosin phosphatase. Myosin phosphatase is an enzyme involved in muscle contraction and relaxation. A normal DMPK gene has a CTG repeat region ranging from 5 to 35. Type 1 myotonic dystrophy is caused by an increase in the number of repeats within the trinucleotide expansion region. The disorder manifests when the CTG region ranges from 50 to 5,000 copies. Due to the extended copies, this leads to conformational changes within the mRNA when the DNA is transcribed. The altered mRNA interacts with the other proteins, leading various pathways becoming dysfunctional. The size of the repeat region in the genes can be associated with increased severity of symptoms. However, repeat region size does not correlate to mean disease, as some patients can be asymptomatic while some show delay of onset. This table shows the phenotypes of DM1 and the ranges of the trinucleotide region for each phenotype and the age of onset. 50 to 5,000 repeats nearly always mean asymptomatic disease. However, it can be shown that patients with 60 repeats can remain asymptomatic into old age, whilst patients with repeats up to 500 are asymptomatic into middle age. Due to somatic mosaicism, CTG repeat size correlates more significantly with age of onset and disease severity below 400 CTG repeats. A correlation between size and severity has only been seen in blood and not in organs. DM1 repeat mutations are dynamic gene defects and show instability with variation in different tissues and cell types, causing somatic mosaicism. CNBP gene codes for the CNBP protein. Its function is unclear at this time, but it is postulated to be involved in the regulation of genes involved in production and use of cholesterol. On top of that, act as a regulator in splicing. The protein possesses zinc finger domains, which indicate it to interact with mRNA to aid in its functional duties. The protein is found throughout the body, but most abundantly in the heart and skeletal muscles. DM2 is caused by a tetranucleotide expansion repeat, which begins to manifest once the repeat ranges from 30 to 11,000 repeats. Like DM1, this leads to the formation of a mutant mRNA and thus dysfunction in various pathways. On DM2 range 30 to 11,000 show marked somatic instability with increased length over time. Thus, the threshold size of disease-caused mutation remains to be determined. Modifier genes affect DM2, such as CLCN1 and SCN4A, and may contribute to exaggerating the DM2 phenotype. CLCN1 gene codes a skeletal muscle chloride channel, CLC1, which is responsible for myotonia congenita. Patients with the CLC1 modifier show more severe muscle stiffness. SCN4A gene codes for the NAV 1.4 voltage sodium channel, which is expressed in muscles, and is another gene implicated in myotonic disorders. It is characterized by severe myotonia. The clinical features of DM2 become much more severe if a patient has both modified genes present compared to only having the mutant allele. Due to this increased severity, it should be easier to diagnose a patient. The mutant gene has lost its function and the ability to form normal mRNA proteins for molecular events. This is the case in both DM1 and DM2. When both DMPK and CNBP are altered, the expanded repeat regions interfere with the local chromatin configuration, which affects expression of both altered genes and those neighbouring the locus. Molecular pathways may be disrupted due to sequestering of proteins, thus making pre-mRNA translational and splicing pathways to become dysfunctional. Due to the conformational changes of the mRNA, the RNA has become stable and is retained in the nucleus rather than being transported into the cytoplasm to be translated into DMPK or CNBP. The mutant form aggregates in the nucleus and possesses a toxic effect, which is said to trigger some of the clinical features of myotonic dystrophy. In DM1, variability is caused by repeat mutations, which can be dynamic and show instability with variation in different tissues and cell types, causing somatic mosaicism. Somatic instability in both DM1 and DM2 gives rise to intra-tissue, inter-tissue and cell type variability and somatic mosaicism over a patient's lifetime. Although genetically distinct, DM1 and DM2 share a common pathogenic mechanism. Experimental evidence supports an RNA gain of function mechanism in which expanded CUG or CCUG containing transcripts accumulate in the cell nuclei as foci, which are responsible for the pathologic features common to both disorders. The mutant RNA form imperfect double standard structures, leading to deregulation of several RNA binding factors, including the muscle blind-like proteins, or MBNLs, and RNA binding protein 1, CUGBP1, which are antagonist regulators of alternate splicing. This diagram shows the postulated pathway in the cell from the nucleus to the cytoplasm and so forth. The model focuses on reduced gene function, missplicing of genes, dysregulation of transcription, and protein translation. The mutant RNA form imperfect double-stranded structures which lead to deregulation of several RNA binding factors, such as MBNL, CUGP1, HNRNPH, and Stauffen1 proteins. MBNLs play a prominent role in DM pathogenesis, as MBNL is sequestered by CUG RNAs in the cell nuclei. MBNL1 plays the prominent role in alternative splicing regulation in skeletal and cardiac muscle. MBNL2 related function to central nervous system. Support for the MBNL proteins comes from loss of function models via knockout mice, which recapitulate multiple features of DM, also show modest effect on alternate splicing regulation in the brain. The loss of MBNL2 leads to loss of postnatal splicing patterns, many of which are similarly dysregulated in human DM1 brain, but not in skeletal muscle. The other protein of great interest is CUGBP1, regulator of alternate splicing and of mRNA translation and stability. This protein does not localize with RNA foci cell. CUGBP1 may play a role in pathogenesis of splicing abnormalities because it is overexpressed in DM1 myoblasts, skeletal muscles and heart tissues, due to PKC-mediated hyperphosphorylation and subsequent protein stabilization and upregulation. It is clear that MBL is depleted from nucleoplasm through recruitment into ribonuclear inclusions both in DM1 and DM2. CUGBP1 overexpression has only been demonstrated in DM1, but not in DM2 via muscle biopsies. This reveals by Cardini that the sequestering of MBNL1 evidently has a central role in splicing misregulation in both types of DM, whilst in DM1 CUGBP1 is an additional pathogenic mechanism not shared besides role in splicing. Other splicing factors involved in early phases of pre-mRNA processing have been found to be altered in DM pathologies. These include snRNPs and hnRNPs. General alteration of pre-mRNA post-transcriptional pathway could be at the basis of multifactorial phenotype of DM patients, as alluded by Perdoni. Staphin 1, it's a protein not sequestered by nuclear foci of CUG mRNAs, and it is found in skeletal muscles of DM1 mouse and humans. Staphin 1 upregulation may have a protective role in DM1 pathology as a compensatory mechanism used by muscle fibers to reduce and or delay effects caused by MBL1 sequestration and CUGBP1 upregulation. In the end, spliceopathy does not show direct cause-effect relationship between symptoms and missplicing. This does not explain the multisystemic spectrum, and this was shown by Baczynski via global array-based expressions and splicing profiles found that DM1 and DM2 skeletal muscles were essentially identical to each other. Thus, splicing may be more of a general phenomenon between DM1 and DM2 patients. DM animal models suggest splicing, RNA foci, and muscle pathology are separable events. This suggests that DM molecular pathogenesis may be more complex, involving changes of gene expression and translation efficiency, non-conventional translation, and microRNA deregulation, such as a novel molecular mechanism found by the random group. RNA transcripts containing expanded CAG repeats can be translated in the absence of a starting ATG, and this non-canonical translation, called repeat association non-ATG translation or RAN translation. In DM1, RAN translation results in the accumulation of DM1 polyglutamine expansion proteins. RAN products appear to be toxic. RAN to be found in mouse stroke patient biopsies and not in controls, which may explain CNS problems in these patients and animal models. The other mechanisms, alternate mechanisms, is miRNA. It has been shown in the myotonic dystrophies that the highly regulated pathway of miRNA is altered in skeletal muscle, potentially contributed to DM pathogenetic mechanisms. Misregulation of MIR1 observed in the hearts of myotonic dystrophy patients may contribute to cardiac dysfunction. The significant reduction of MIR1 appears to be caused by the expression of expanded CUG repeats and subsequent MBNL1 nuclear sequestering. It has also been suggested that miRNA can be used as a prognostic and diagnostic marker. Overall, no one animal model has completely incorporated all aspects of multisystemic phenotype in type 1 or 2. The DMPK knockout mouse failed to reproduce a complex multisystemic DM1 phenotype, thus suggesting the haploinsufficiency of the gene in the DM1 locus is not the primary mechanism of the disease. Whilst CMBP knockout was consistent with DM2 and no missplicing, thus strengthening the role of CMBP in disease pathogenesis in type 2. So can we explain myotonic dystrophy genetically? Well, to some extent, but the short answer is no. We have animal models that do not concur with the current molecular understanding. We cannot explain the different phenotypes between the two types of myotonic dystrophy, and why does type 2 not invoke genetic anticipation? Spliceopathy does not show a direct link to multisystemic nature of the disorder, and thus indicating there are other mechanisms involved in myotonic dystrophies, such as the use of microRNA. Other areas of concern are asymptomatic patients with repeat regions for pathology and those who show symptoms of myotonic dystrophy at a later stage, what causes this delayed onset and or lack of symptoms compared to someone who has the same repeats and similar molecular background. Could this be related to environmental factors? Clinical treatment detection. Diagnosis is performed in two stages to determine the clinical features using family history and the symptoms exhibited, and then to get a genetic confirmation via PCR and southern blotting. PCR used to detect repeat lengths less than 100 and southern blotting used to detect a repeat length larger. And this is primarily used to confirm type 1 myotonic dystrophy. For type 2 myotonic dystrophy, conventional PCR cannot be used due to extremely large, up to 11,000 repeats size, and somatic instability of repeats, thus the need for the three-step procedure using RT-PCR. As mentioned before, for DM2, due to large phenotype variability and large number of individuals with milder symptoms who remain undiagnosed, patients over the age of 70 with slowly progressive muscular weakness may not be referred for investigation. In situ hybridization should be employed into a clinical setting as it permits a differential diagnosis between the two types, hence it can provide a rapid approach in diagnosis within a pathology lab. Due to the variability of the phenotype and slow progression of the disease, it can take a very long time to confirm either types of myotonic dystrophy. In terms of treatment, there is no current cure for any of the myotonic dystrophies. Active management of the disorder with physical and psychological support and family planning are the way forward for a patient. For active management, assistive devices are prescribed as disease progresses, such as wheelchairs, cataract removal, monitoring of the heart conductive nature. Cardiorespiratory disorders are responsible for 70% of the mortality in type 1 patients. Cognitive difficulties in adult life appear to be associated with decreased cerebral blood flow to frontal and anterior temporal lobes and decreased brain volume. Etiology of this is unknown, but has been stipulated to the related to the toxic effect of accumulation of mutant RNA. Planning: there's prenatal screens, so just in case they may wish to have an abortion if their child has the mutant allele. There's pre-implantation genetic diagnosis, so in vitro fertilization again to plan ahead and not make sure the child or progeny do not have this mutant allele. Finally, if a patient with DM decides to have childbirth, have a child, She will generally have difficulties with giving childbirth due to the weakness of her uterine muscles. This image shows RNA dominance and the molecular therapy targets in myotonic dystrophy, i.e. the target and strategies of gene therapy. Currently, antisense oligonucleotide gene therapy is undergoing phase 2 trials. It was found that the drug that they were using was able to reduce DMPK mRNA by up to 70% in some muscles and 50% in the heart. The new antisense drug was also long-lasting, as it was still detected in muscle tissue 13 weeks after the final dose was administered. Overall, the drug was safe and effective at targeting the DMPK mRNA and may be considered for future use in drug trials. More research is necessary to highlight important splicing changes in DM1 and determine whether reversing them would be beneficial as a future therapeutic approach. Thank you for listening to my presentation on myotonic dystrophy.